Hey guys, and welcome to this week's case on Master Your Medics. You know, they say that if you're going to have a STEMI, the best one to have is probably an inferior MI because it has the lowest mortality, something less than 10%. But how about if you have the complication of an RV infarction associated with that inferior STEMI? It does change things, and these patients are far sicker. Let's take a look at this case and see how they make out. Okay, so this was a 78-year-old patient with acute onset of severe epigastric pain after she walked outside her apartment. Now, bystanders saw her, they saw her hunched over and dropped to the sidewalk and called 911 immediately. And, she also complained of lightheadedness, she was nauseous, and she had a prior history of MI, diabetes, and stroke. And when paramedics got there, they found her to be pretty ill appearing. She was lying on the sidewalk in moderate pain and very ill appearing and diaphoretic. There's no obvious signs of trauma, and her vital signs, well, she looked pretty sick and hypotensive with a blood pressure in the 80s and SATs in the 93% range, and she was confused appearing. Right, here's the first ECG they obtained. Now take a look at this, pause the video here, and see if you can make the interpretation. Now, there is some artifact, present in this ECG, but even through that artifact, you can see the inferior leads are very concerning, right? There are elevations in 2, 3, and AVF, along with some elevations in precordial lead V3, with depressions in AVL and precordial lead V2. And take a look at precordial lead V1. The ST segment is isoelectric. The T wave is inverted, which is fine, but that the finding of the isoelectric ST segment in V1 with ST depressions in V2 made the paramedics somewhat concerned about this being something else. Something else might be going on in this case, right? So they went ahead and they obtained right-sided leads, right? V4R is what they got. And in the pre-hospital setting, this is pretty helpful because in a patient with chest pain, high risk, hypotensive, they were suspecting an RV infarction. And, they considered taking this patient to a hospital that had PCI capability, but was far beyond the nearest facility. And so, I wonder if you agree with that call. They actually took the patient in transport, and while they're transporting her, she got a little sicker. She got a bit more hypotensive, chest pain continued. She actually got aspirin. They held off on the nitroglycerin because she was too hypotensive, obviously. Morphine was a good possibility. It was a possibility, but they gave her fentanyl instead and fluid boluses. They did not give her pressors, as her blood pressure actually improved somewhat to the fluid boluses. So their concern was an RV infarction in the setting of an IMI, given the appearance of lead V4R. Now, the question you got to ask yourself is, are there elevations of the ST segments in lead 4R? And if you look at the ST segments, I think the best thing to do is to try to identify the J point. And the best way of doing that is to look at the lead just below precordial lead V5. And you can actually find the J point there pretty easily. And this corresponds to a J point in this region here, giving you the sense that, yes, there are in fact some elevations of about 1 millimeter or more compared to the baseline over here. And the same thing is true for the adjacent complex too. Here's the J point in lead V5, and it corresponds to a elevation of the J point by about 1 millimeter or maybe a little bit more, raising the concern of an RV infarction. So RV infarction, is it important to make the diagnosis? Well, it is if you're gonna, if you need to manage this patient acutely and make a decision to take a patient to a PCI center. Remember that RV infarction is seen as a complication of 40% of all infra MIs. That's a huge number. That's almost half, actually, right? So super concerning, I think. Remember, RV infarctions are preload sensitive, so hold off on nitrates if you can in a very ill-appearing patient who has a soft blood pressure. I would probably hold off on that and go straight to narcotics, actually, in this case. Fluid bolus strategy, I think early fluids are a great idea. I go with 300 cc's at a time, times 3, and then reassess. And if you have ultrasound, it's really helpful to look at the function of the RV in such cases. And if they are fluid unresponsive, I go straight to pressors. And I'm actually ready with the pressors as soon as I see something like this because of the high likelihood that they actually need them, right? So ECG findings suggestive of RV infarction. Lead V1 has the best view of the RV. Remember that, right? So that gives you a lot of information right there, and the relationship of the isoelectric ST segment in V1 compared to depression in V2 is also a really helpful sign. The combination, however, of ST elevations in V1, right, compared to depressions in V2 has the most specificity. So when you see this pattern, be really concerned about this. And limb lead 3, remember that the limb lead 3 by itself has the best view of the RV compared to limb lead 2. In this little diagram, you can see that limb lead 3 looks directly at the RV, whereas lead 2, not so direct. And so when you see an RV infarction, like in this case, if you see elevations in limb lead 3 greater than 2, that is a really important giveaway, I think, for you to consider RV infarction and then go on to get right-sided leads. And when you have this suspicion of all these other findings suggesting the possibility of a RV infarction, best thing to do is get just a single V4 right-sided, and the diagnostic accuracy of this one lead having an elevation of the ST segments of 1 millimeter or more is 83%. So it's really helpful to have. And this particular patient went to the cath lab. She had 100% occlusion of the proximal RCA and did just fine, thanks to the quick thinking by the part of the paramedics. A couple of ECGs just to practice this pattern. Here's V1. You can see V1 being isoelectric and V2 being very depressed. So this pattern here should make one suspicious of the possibility of an RV infarction. Here again, there's V1, here's V2, and let's blow it up, and very isoelectric pattern here, and you have some depressions of V2, and then again, that's also patient had an RV infarction. And again here, this is actually, you can see maybe some elevation of the J point here, and this is what I was talking about when you have this kind of a pattern. Let's blow it up a little bit here. When you have this kind of a pattern here, you see the J point being elevated, and the ST segments here are down with huge T-wave inversions here. That has the most specificity for this being an RV infarction. So be very careful of this pattern when you see it. Okay, so that's it for this week. Thanks so much for watching. Put your comments and questions below. Looking forward to seeing you guys next week. This is Sush. Take care.